Hello everybody. Well, this lecture is about goniometrics, and you will be able to find PowerPoint which is called Goniometrics. Okay, it's very of course important because in this course we will learn or relearn, if you will, the skill of measuring range of motion. So of course goniometer as an instrument is used to measure and record active range of motion and passive range of motion, but as I mentioned in the previous video, that we do not measure active assistive range of motion. So why such a complicated word, goniometrics? Well, it actually derives from the Greek language. Gonio means angle, and meter or metrics, actually, it's a measurement. So in other words, in plain English, we measure an angle of movement, goniometrics. Okay, so let's go to the next slide. Why do we take measurements in the first place? Well, there are many reasons. So let's talk about at least few of them one at a time. To determine presence or absence of dysfunction. Well, to understand this better, we have to start from the basic knowledge what would be considered normal. Not everybody is, of course, the same. So normal, it's, let's say, a scientist took 10,000 people, measure all of them, divide all the measurements into the number of people, and they came up with the numbers, and we're going to consider that normal. Well, if you do not know what are normal numbers, let's say for shoulder flexion, it's from 0 to 170 to 180 degrees, and if you don't know that, then you wouldn't know potentially if your patient who has only 0 to 150 or 140 degrees for shoulder flexion, you wouldn't recognize this as a normal or abnormal. So in order to know that, you must know the normal numbers first. To establish baseline, so as a therapist, and especially as an OTR, when you are doing the measurements for the first time, you have to know where the patient is right now. You have to know where the patient was in order to try to establish good goals which are going to enable patient to come back, hopefully, to what it was, to his or hers normal. Objectively measure amount or lack of progress. This is very important for the insurance purposes. Insurance people are not healthcare providers, or at least not most of them. So they are business people. They know numbers. They do not understand necessarily our procedures, protocols, our ways of doing our profession. So we have to prove to insurance companies that yes, indeed, patient is doing better. What's better way to document that for business people than numbers? So we use numbers in goniometry and in manual muscle testing to objectively measure if the patient indeed improved or not. Okay. In addition, it helps to set realistic goals. You are all working OTAs, so you know that a lot of people have completely unrealistic goals, and even more than patients, their family members have unrealistic goals at times. So the measurements would objectively justify our decisions for treatments, and at least give some idea where patients should be at the end of our treatment, and really establish realistic goals. Research the effectiveness of therapeutic techniques. If your technique doesn't work and you do not see any progress in the following few days then it's perhaps you have to change your technique. We always gonna start with giving a patient a benefit of the doubt. We're not gonna say, well, my technique was amazing, I just did it, and patient didn't react to it, therefore patient, it's not going to improve, let's discharge him home. Well, no, we're gonna give the patient the benefit of the doubt, and we're gonna re-examine what we are doing or not doing and change our approach. So it's very important in that aspect. And of course, fabricate orthosis or issue adaptive equipment. So understanding of range of motion, it's going to be extremely helpful. When do we take measurements? Well, if active and or passive range of motion is not within normal or functional limits, you're not gonna waste your precious time with your patient to measure something which obviously is working. You ask patient to raise the arms up, and if the patient does this, you know that bilateral shoulder flexion is with normal limits, or at least with functional limits. Do not waste your time on actual goniometry. When you are asking your patient, please bring your arms up, and the patient will do something to that effect, well, what are you going to do? You know that the right shoulder flexion is normal or with functional limits, and the left it's not. So you're gonna take measurement on the right to have a baseline, and then measure the left and establish appropriate course of action. So when do we do this? Well, during initial evaluations, during re-evaluations, and of course discharge. So let me talk a little bit about screening. Screening is, and you of course, probably most of you, if not all, are well aware of what screening is. Screening is not evaluation. It's not an official evaluation. Therefore, it is allowed for OTAs to do it. So I do believe that most of you probably did screenings. And what are we looking at? We're looking first and foremost into the medical chart. We talk to nurses or any other significant other who can give us information about the patient. We're looking at the past tests, how the patient could perform that activity some time ago, and how is doing now. So we, by observation, assessing active range of motion, perhaps even passive range of motion, but it's not official evaluation. So we do not do officially goniometry or manual muscle testing after screening. When you decide that yes, you saw some differences, you think that the person can actually benefit from evaluation and OT treatment, then you of course inform your OTR that evaluation is needed, and OTR is informing the medical doctor, gets the prescription, and the next step would be to actually perform the official evaluation. And as OTRs, you will be required to do the same thing. So you're not going to screen this and report to other OTR, you're going to screen, and if appropriate, you are going to take that case. Non-pathological factors affecting range of motion. There are some pathological factors, we're going to talk about that, but also non-pathological factors which could affect potentially range of motion, and similarly manual muscle testing. Pathology is really too easy to understand. You broke your arm, you won't be able to move it, you are in the cast, or your patient of course. The patient is going to have the cast removed, the muscles are weak, and the range of motion and manual muscle testing are going to be affected. But pathology is easy to understand, but non-pathological factors are also very, very important. So the first one is sex. Typically, now we are going to stereotype. Sometimes stereotypes are bad. We know all about those. But sometimes stereotypes are good, and we have to keep that in mind, that stereotypes works in many instances. So for example, sex, stereotypically speaking, women are more flexible than men. Very simple explanation. Men have more muscle mass, and muscles, of course, do not allow freedom of movement as more flexible tissues. Age, child. Let's take into consideration a child. Very flexible. Child can tumble down the stairs and nothing gonna happen. Do not try to do that at home, or do not try to push your grandma down the stairs, because it's not the same. Right? So age is a huge influence. Hereditary factors. We try to fight with genes, but a lot of times we kinda doomed to them, and hereditary factors play a huge role with everything what we do, everything what we are, what we represent. Of course, it's not 100%. That's not what I'm saying. But the hereditary factors play important roles in flexibility of the body. Occupation. I would expect different results if I measured range of motion, let's say a ballerina or some other sports which require a lot of range of motion, as opposed to construction worker. Construction worker have very tight muscles. So occupation is, of course, very, very influential. Physical training. Take into consideration somebody who goes to the gym and exercises regularly, and a couch potato. Anxiety or stress, especially in elders, especially if they have a history of falls. So anxiety and stress make them rigid, and therefore decreases range of motion as well. So anxiety and stress and fear of injury, it's kind of hand to hand. Okay. So goniometer, as you can see on the next slide, you can see the picture of it. Of course, you saw it, you use it, and if not, this course is going to remind you how to do that. We got different type of goniometers. The only really different kind of goniometer is the digital one, or the finger one. But other goniometers are just different sizes, really, but the parts of the goniometers are the same. You have a stationary bar, which is easy to understand because the stationary bar is always attached to the scale. Then you got movable bar, the one which actually goes around the scale, and you got fulcrum, or the center of the goniometer, which is the fulcrum, or you finding the axis of rotation, you placing that fulcrum of the goniometer on the axis of rotation of the joint in order to properly measure that. But we will talk about that extensively during our face-to-face meeting. And we already discussed this, so on the next slide you can clearly see on the right hand side the translucent or semi-translucent goniometer, which we will use for many joints, and of course bigger goniometer, bigger joint, smaller goniometer, smaller joint. And on the left hand side you will see that very different goniometer, which is only digital goniometer. It does not work in any other joint of our body. However, it's still basically composed of the same components. You have a stationary bar which is attached to this scale. You have a movable bar, and you have a fulcrum which you are going to put on the actual axis of rotation of each joint being measured. So we are using 180-degree scale simply because a vast majority of people can't perform any other movement than up to 180 degrees. Sometimes you have those super hyper extensions or flexions of certain joints. You will simply add those degrees to the 180. So how do we record our findings? You have to state the position of the patients while when the patient was actually being measured. There is a big difference between sitting position sometimes, or standing position, or laying down position, etc. But we will learn this hands-on, and I will remind you about all of that. Range of motion is recorded as an arc of motion. Remember what I said earlier, that it's a rotationary movement. That's how we measure range of motion, through the arc of motion. That's why you got fulcrum, and the movable bar goes around that fulcrum to capture that movement. Again, when you are recording, and we're gonna see that very soon on the slide, you have to use two numbers, the starting point and an ending point, but I'm gonna come back to it in a minute. So what that means, range of motion recorded as an arc of motion, simply means that you have to use two numbers, starting and ending. You have to be very clear if that motion was passive or active, and never active assistive. And again, I mentioned that before. Why? Because you cannot be clear how much effort was done by patient and how much work was done by you as a therapist. Therefore, we do not use active assistive range of motion, period. But you have to be very specific if what you documented was passive range of motion or active range of motion. So let's take a look how to record those findings. So normal, and this is just an example, but it works to any given joint in a human body. It's a rule of thumb, really. So normal, well, normal, we always want to start from 0. This is our starting position. So elbow flexion, this is our 0, and this is our flexion. How much flexion patient has, right? So normal is everywhere from 135 to 150 degrees. Everything in between would be considered normal. So if your patient is normal, for example, has 140 degrees, you would document from 0 to 140. That's it. Well, the next one is limited elbow extension. Line like this means extension, and V means flexion, right? So elbow extension, you can clearly see that it's from 15 degree to 135 to 150. Just by looking at those numbers, you instantly know that patient lacked that 15 degrees. Therefore, we're not gonna use not the minus sign, because the minus sign means more than 0, because it works the other way, because we are working with that arc. So 0 is neutral. More than 0 would have to have a sign minus. I hope that I don't confuse anybody here. So if you do not see the sign minus, and in mathematics we do not put plus sign, we just take it for granted that if there is no minus sign, that means it is a positive number. So in this case, positive number is not good. Negative number, possibly it's not good. We want that 0. So clearly, in this case, 15 degrees, that's it. I cannot go all the way to 0. I'm stuck over here. So that's why I mentioned in the previous slide, is so important that we always document this as an arc of motion, meaning you must put two numbers down, from 0 to where, or if not 0, from what to what, because that first number will give you as much information as the last one. 0 means no problem, but no sign, but positive, but more than 0 means limitation, and with the minus sign means hyper. In that case would be hyper elbow flexion, extension. I'm sorry, because I put it as a hyper extension minus 20. I cannot do that. Maybe some of you can. If you have maybe certain professions or you are an athlete, that would be more for those people, right? So limited elbow flexion, the next one is from 0, which we want, but only to 100. Clearly flexion is limited. Then you have limitation in elbow extension and flexion. Therefore, that 20 means limitation in extension, and 100 only patient can go to 100. That's clear limitation, so 20 to 100. Hyperextension minus 20 to normal, which is between 135 and 150. And you can probably play with those numbers and find other ways of, each patient is different. Those numbers are just to show you that how to document, and how important is that we have to use two numbers when we're documenting and never one. Okay, how to document goniometrics measurement: patient name, age, sex, and diagnosis, patient name, therapist name, and you will have to sign with your, of course, OTR, or right now OT, quota, or whatever your designated abbreviations are. You have to use it. Date and time of measurement, very important. I have to know when the patient was measured, and preferably what time, in the morning or in the evening, because this sometimes can make a huge difference as well. Of course, what joint and what motion was being measured. Type of motion, very important, active or passive. You have to include also subjective information such as pain or swelling, because pain or swelling can of course diminish range of motion or strength capabilities. Objective information, crepitus, meaning those kind of sounds, like different sounds, like there is dehydration perhaps of the joint and a muscle, sometimes tendons or even ligaments. Sometimes they don't glide as they should, and the joint makes funny noises. We're gonna call this crepitus. Capsular pattern, it's something we do not have to cover right now. It's not that important. You can disregard this. And of course, describe deviation from the recommended position. When we see each other on campus, and when I'm teaching or reteaching you how to use the goniometer, you will see that there are recommended positions. Patient should be in sitting, or patient should be in supine. Is this always possible? Absolutely not. Can you still make those measurements? Can you perform those tests? Absolutely. But you have to document that the position was different. What was the position? That's gonna be the part of your documentation. So that's it. That's the end of goniometric PowerPoint. It was very quick, very easy. This particular information is in Pedretti book, so I strongly encourage you to read Pedretti chapter about the goniometry. You will find more information in Pedretti book. But basically, what else I would like to add is what's the normal. It could be different for different people, and I don't want you to think that, oh, if it's not normal numbers, it's let's say shoulder flexion, it's 0 to 170 to 175, or elbow flexion from 0 to 135 to 150. And if your particular patient is not there, you're gonna document this. Oh, the patient is abnormal. Well, this might be true, might not be true. So you have to take into consideration the big picture. Look at your patient and ask yourself, is 85-year-old woman capable of doing this? Well, no. Therefore, maybe it is normal. It is normal for this patient. She can raise her arms only to 120 degrees. Guess what? She is 90. Majority of 90-year-old people would do that and not more. Is this normal? Yes, it is. Let's take another example. I don't do this lately because I'm using like a home gym to exercise, but I used to go to the gym for years. And there were some guys over there which looked to me almost distorted. They were so big, so huge. Then when they flexed the arm, the muscle was so big, the forearm was so thick that that's probably as far as they would go. Now, how they brush their own teeth or comb their own hair, it's anybody's guess. They probably need adaptive equipment, if you ask me. But the point is that is it normal or it's not normal that the bodybuilder can flex the elbow only to 100 degrees, let's say, for argument's sake? For this particular patient, yes, it is normal, or person. So, in other words, if you take into consideration a ballerina or somebody who plays different sports which require hyper extensions or hyper flexions or hyper whatever, are you going to measure it and then say, oh, you have so much of hyper extension that this is abnormal? Again, the answer is no. This person trained herself or himself to be that way. Therefore, it's normal for this person. So you always have to take into consideration the big picture. Where this person is coming from. Who are you dealing with? What is the profession? What are the leisure activities? What the patient could do before you see that patient? And go from there. Okay, so why is important to know normal numbers? Well, because if you don't know normal, then you would never be able to say if something is abnormal or not. But if you have a patient who is supposedly abnormal, take a look at the big picture and go from there. All right, see you soon. Thank you.